Aloha, I'm David Dykman and welcome to AAPI Today I have the pleasure of interviewing the legendary Dr. Richard Bernstein, a man who's changed the trajectory of my life as a diabetic and whose teachings and knowledge has allowed me to thrive as well as many others with diabetes. Dr. Bernstein is a physician and advocate for a low-carbohydrate diabetes diet to help all diabetics achieve normal blood sugars. He himself is also a type 1 diabetic, and his private practice in Mamaroneck, New York is devoted to all diabetes as well as prediabetes. He is a fellow of the American College of Nutrition, the American College of Endocrinology, and the College of Certified Wound Specialists. He has written and published over 6 books and has written countless articles on all aspects of diabetes. I am the producer of Dr. Bernstein's Diabetes University on YouTube, a resource of over 200 videos covering all aspects of diabetes. But today, I'll be talking to him about the very basics. This is a perfect video to start with if you or someone you know has been recently diagnosed. You'll hear about the consequences of elevated blood sugars, how to normalize your blood sugars and even avoid those complications, which lab measurements are important and which are unimportant, what foods you should eat if you have diabetes, and the foods that you should try and avoid, as well as trying to avoid outdated advice on running high blood sugars, why the obesity crisis reflects an addiction to certain high-carb foods, and how you can really and truly thrive with diabetes. Thank you for your time and watching this video. Be sure to check out the rest of the site and our other experts, as well as Dr. Bernstein's Diabetes University on YouTube, and I'll link a couple of articles that Dr. B has wrote himself. Thank you. Mahalo.
Okay, so let's begin.
All right. Hi, Dr. Bernstein. It's a pleasure to chat with you. Would you start by please telling us a little bit about your life experience with type 1 diabetes?
Well, I developed it at the age of 11. And I know exactly what year it was because it was shortly after the atomic bombs were detonated, and that was in 1946. And in those days, we had to inject insulin ourselves, sterilize glass syringes and needles. I'd have a little pot that I cooked them in on the stove every day, and you'd take 1 shot of insulin a day, and it was a big shot, and the needles would get dull and get hooks on them, so we would take a honing stone and sharpen the needles periodically, and a single needle would probably last for years until you bent it, and then you'd have to throw it away. We didn't know what our blood sugars were. There was no way for a patient to measure his own blood sugars. So you could go very high and die from high blood sugars, or very low and die from low blood sugars. So you were constantly walking a tightrope where you didn't know where you were and when you'd be dead. I had several occasions where I lost consciousness due to very low blood sugars, and on one occasion, I had a convulsion and chipped a front tooth, and I looked like Dracula for many years, until after I was married for 30 years, my wife made me get my tooth bonded. She got tired of me looking like a vampire. It was a kind of torture, and I was fortunate enough to survive and go through college and engineering school, and I became one of the first biomedical engineers, which they didn't have biomedical training, but I worked for a company that made clinical laboratory equipment, and happened to see an ad in one of our periodicals. A competitor had made a device for emergency rooms to tell the drunks from the diabetics if an unconscious guy was wheeled into the emergency room at night when the labs were closed. And this thing, so anyone came in unconscious, they checked their blood sugar with a finger stick. And I said to myself, if I could check my own blood sugar, I'm an engineer, I could figure out what to do about it and maybe stop them from the wild fluctuations. And by the way, the wild fluctuations, by this time I was married and I had small children, they were taking the brunt of my low blood sugars, where you could become irascible, violent, unreasonable, just like an intoxicated person.
Right.
And here I was behaving this way pretty frequently, especially on weekends when I was home with the family and we had a boat and I'd be working on the boat, and that exercise would lower my blood sugar and I'd be troublesome. So it was really torture for my family. And when I discovered that this device for measuring blood sugar existed, I had to get one. Well, fortunately, I had put my wife through medical school, and I was able to order one of these devices, even though it was only sold to hospitals and physicians. And it cost $650. I could show you one of them. I think it weighs about 6 pounds. And I created a rechargeable battery for it, put in a little contact. Since I was an engineer, I wired it up to get a rechargeable battery, and I would carry this around me in a shoulder bag. So it was quite a job to lug around a 6-pound, looks like a Bible, wherever I went. And you had to squirt water on it in order to get the blood off of it. So if I were, say, visiting someone at another business and I wanted to do a blood sugar, I'd look around for a flower pot. They used to have little plants in the lobbies with little trees and whatnot. And to wash the blood off the blood sugar strip, I'd find a tree growing in a pot and squirt the water on it, shake it off, and then measure my blood sugar. Well, that permitted me to figure out a way to keep blood sugars normal around the clock. And that enabled me, by having normal blood sugars, after I had already, by then I was in my 30s, had kidney disease and a number of other complications of diabetes, which were very unpleasant. And I was able to reverse most of these long-term complications and survive. I'm now 87.
Could you talk through your medical qualifications and your clinical expertise?
Well, I went to medical school, Albert Einstein College of Medicine. I actually got graduated in 3 years. I was actually the youngest person in my college class at Columbia College, and the most elderly in my medical school class. I finished my training when I was 49 years of age. Because I was interested in learning how to treat the complications of diabetes, I had already figured out how to control the blood sugars, but I was not exposed to complications that other people had. And one of the more challenging ones was foot infections and ulcers and amputations. And during my internship, I was able to arrange to get special training by the world's authority on the diabetic foot, who also happened to be at my medical school. His name was Heinz Lippmann. And once I started practicing, I was not loaded with patients. You don't all of a sudden have a lot of patients. I was able to devote 1 day a week to working in his clinic. And I eventually became director of the clinic, which is the Peripheral Vascular Disease Clinic, which I ran for a number of years, and discovered or invented a number of new treatments and whatnot. One of the things I discovered related to the fact that there are about 500,000 amputations of diabetic feet and legs every year in this country, many more worldwide. And I discovered in our hospital, just by interviewing every patient who came to our clinic, including those who had already had one leg removed or one foot removed, I discovered that what preceded the amputation in all these cases was something called salami surgery, where usually someone would try to file down or remove a callus, usually a podiatrist. The effort at removing the callus the effort would become infected because they'd cut off too much of the callus, and then they'd have to first cut off a toe, then a forefoot, then a whole foot, then a lower leg, then all the way to above the knee. So this salami surgery is still to this day common in diabetics. The American Diabetes Association, until very recently, was recommending that calluses be chopped off on every diabetic, which is the worst thing that you could do. And I would not have known this if I were not working in or running this clinic. So when you talk about credentials, I was the director of the Peripheral Vascular Disease Clinic, and I now I still have the same private practice I had when I started back in 1983. We also do a video series called Dr. Bernstein's Diabetes University, for mostly viewed by diabetics, but also by many professionals. Unfortunately, most professionals in the field of diabetes do not know how to treat the disease or control blood sugars. The American Diabetes Association, until very recently, advocated very high carbohydrate diets, which make blood sugar control impossible. And they're still advocating high blood sugars for everybody, which cause the many complications that Dave has probably discussed: blindness, kidney failure, heart disease, makes these cutting of calluses more likely to get infected because of the high blood sugars. There are probably 100 or more different complications of diabetes: erectile dysfunction, Dupuytren's contracture, which leads to sort of a claw hand, deformed feet, frozen shoulders. Anyway, it's very frustrating to see that doctors are not being adequately trained in treating diabetes or normalizing blood sugars. In fact, there's no institution that advocates normal blood sugars. And if you go to institutions of learning, medical schools, I don't know of any where normal blood sugars are being advocated. And I don't know of any physician other than myself who knows how to normalize blood sugars.
Right.
And when I advocated speaking to physicians, they challenge me. Now, there are probably reasons for this. Doctors nowadays, or maybe going back even a long time, are afraid of getting sued. And if they're dealing with patients who require insulin, or who use insulin, I should say, insulin can be a very dangerous product if you don't use it properly. And the doctors are never taught how to use it properly. They're used to using industrial doses, giving people large amounts of carbohydrate, which they try to cover with large amounts of insulin, and they get unpredictability. Okay, another question?
Yeah. So many people watching this video will be recently diagnosed with prediabetes/diabetes. Can you talk about why they've been diagnosed and what the root cause of diabetes is?
Well, there are probably multiple types of diabetes and multiple causes. When you deal with type 1 diabetes, which is principally an autoimmune disorder, it's tough to pinpoint a single cause, and even tough to pinpoint multiple causes. There are certain antibodies. A few years ago, we thought that there were many years ago, we thought there was one antibody that attacked the organ that makes insulin, the pancreas. And then they learned of more and more antibodies. And now we know that there are hundreds of possible antibodies that could attack different parts of the pancreas, leading to diabetes. So we can't even focus on a single immune target. Type 2 diabetes, which usually hits older people, is principally related to being overweight or obese, because when people have abdominal fat, especially down inside below their muscles, they tend to be insulin resistant, and the insulin they make is frequently not adequate to keep their blood sugars normal. And their blood sugars go up a little, and high blood sugars are toxic to the beta cells of the pancreas that make insulin. So by continuing to be overweight, especially continuing to eat high carbohydrate foods, they're bringing about higher and higher blood sugars that destroy more and more beta cells. That's a simplistic way of looking at type 2 diabetes. And there are, you might say there's a whole spectrum of diabetes between type 1, where some people make absolutely no insulin, and type 2, early type 2, where they may make a lot of insulin but are resistant to it. So we can't point a finger on anything specific. Uh, for example, there are some viral infections, such as cytomegalovirus, that are associated statistically with the onset of type 1 diabetes. Um, Here we have this COVID epidemic, and that is associated with new onset diabetes. Um, so it's the answer to the question is not simple. It's complicated.
So, what can be, or can you tell us some of the consequences of elevated blood sugars and some of the examples from your clinic of diabetics that have had some of these consequences?
Well, uh, a common one is frozen shoulder, uh, which affects a number of my patients. We know the mechanism by which it occurs, and there's a whole family of musculoskeletal complications of diabetes where a protein called collagen, which appears in tendons, connective tissue, gets glycated. That is, glucose sticks to this protein and causes the fibers that normally slide past one another smoothly to be glued together. Glucose acts as a glue. And then you try to move a limb and you tear the fibers. And now you get pain when you're moving and maybe even when you're not moving. So we have frozen shoulder. We have carpal tunnel syndrome, which has to do with glycation of collagen in the carpal band that surrounds the nerves and vasculature in the wrist. And that when that carpal band gets glycated, it thickens up, presses on the median nerve, and you get weakness in the hand and fingers. There's Dupuytren's contractures, where the flexor tendon of the fingers, the tendons that flex these fingers, get glycated, and you find that these people develop claw hands. It usually starts with the fourth finger, but eventually spreads to all of them. So you'll see diabetics with claw hands, and sometimes those claw hands are painful. There's kidney failure. Kidneys are damaged by high blood sugars. The blood vessels in the retinas of the eyes are damaged by high blood sugars, so it's a leading cause of blindness. It's the number one cause of kidney failure, maybe the number one cause of blindness in this country. It's a major cause of heart disease, heart attacks, major cause of strokes. So, although we can't say that it's a major cause of cancer, it is associated with higher rates of cancer. There are higher rates of cancer in diabetics than in non-diabetics. So it's very possible that causes of death in diabetics are frequently, on the death certificates, are frequently not attributable to the diabetes, even though the patient may have died as a consequence of the diabetes. So if someone died of a heart attack or a stroke, it'll say heart attack or stroke, even though those conditions may have been caused by high blood sugars. So there's a very good likelihood that in reality, diabetes is the leading cause of death in many modern countries.
So, what can be done to stop these complications and even in some cases reverse them?
Well, in my case, major complications were reversed in that I certainly had kidney disease uh, with large amounts of protein in my urine every day, and that's no longer the case. That was reversed. I had other complications that were reversed, such a condition called Munkeberg's atherosclerosis. Um, and it's almost a question that's impossible to answer because the powers that be, the people, the authorities that write the guidelines, do not support normal blood sugars. And the medical schools have no interest in teaching doctors how to achieve normal blood sugars. For example, a few years ago, I called the physician who's in charge of teaching medical students at my medical school and offered to give there were maybe four hours of lectures that she was giving to the medical students, and I offered to give one or more of them, and she said, what would you talk about? I would talk about the importance of normal blood sugars and how to achieve that. And she said, well, that's too radical. We could never advocate anything like that. I've been blackballed by groups that advocate high blood sugars.
Right.
I mentioned before that there's such a thing as litigation. There's a lot of lawsuits going on against doctors. And doctors are therefore afraid of getting sued. Now, they don't know how to prevent severe hypoglycemia and possible death for people who use insulin. So they advocate that people who use insulin should have very high blood sugars. Their theory is that the further away you are from normal, the less likely you're going to go too low and you die and your family will sue the doctor. And that's reasonable. And why do these doctors not know how to treat diabetes or handle insulin safely? Because no one's taught them. So now, if there's a demand from the patient end, or if doctors are getting sued because patients are getting complications, that would be great. The trouble is that when a patient gets the complications of diabetes, if there's a lawsuit, the doctors will say, or an expert witness will say, this is a natural consequence of diabetes. We expect this. It's bound to happen. You don't find any diabetics without these long-term complications. So it's a losing battle.
Yeah.
Not for the doctor, but for the patient.
In your book, Diabetes Solution, you have a strict guide of no-no foods, for lack of a better term, or foods that you should avoid. And you also have a list of foods that people should actually seek out in their daily diet. So would you summarize these lists?
Well, the foods that people should avoid as far as diabetes is concerned, are foods that rapidly raise blood sugar a lot. So that would be foods that rapidly get converted to sugar, and that would include fruits, um, uh, grains. It's very simple to demonstrate how any grain product, whether it's oatmeal or whole grain bread, will rapidly raise the blood sugar. There are two ways to do it. You could feed it to a diabetic and see what happens to his blood sugar, or you can use what's called a Clinistix or Diastix, which is a little plastic strip that's used to test for glucose in urine. And you can take, let's say, a bit of whole grain bread, chew it up, mix it with your saliva, which breaks down the glucose precursors in the bread, converts them to glucose right there and then in your mouth, spit it on this little test strip, and it'll rapidly turn a dark color, indicating that you've made pure glucose just by mixing the bread with your saliva. And this applies to potatoes and carrots and any starchy foods. It applies to fruits. So what I advocate is that you eat a lot of protein, and most people nowadays don't get enough protein, especially if they're exercising. And so I advocate that you eat protein foods and low carbohydrate vegetables, things like string beans, asparagus, broccoli, cauliflower. I think we have a list of something like 40 vegetables in my book that do not rapidly get turned to glucose.
So what labs do you typically get for your patients, and what labs would you consider to be the most important or the most unimportant for diabetics?
I do probably more labs than most doctors because I want to get baseline data. I think that one important test is called the hemoglobin A1C, which is a test for the average blood sugar over the prior 4 months or so. So it tells me what are we starting with. But it happens that about 85% of my new patients are also hypothyroid. Autoimmune disorders come in clusters. I think I once counted them something like 6 or 7 autoimmune disorders, one of which is hypothyroidism. So I check several thyroid tests. Free T3 is the most important. We also check free T4, and we also check anti-TPO, which is for thyroid antibodies. I discovered and published the fact that about 25% of my new patients that I haven't seen before, have an immune deficiency disorder where they're not making enough antibodies. We call it CVID, common variable immune deficiency. I have a severe case of it, and I've had it long before I got the diabetes. I was born with it. And about 20%, 25% of my patients have mild cases. I'd say of that 25%, 10% of those have severe enough cases that they suffer consequences, which could be frequent infections or even malignancies. For example, I have one patient who was a non-smoker, had an immune deficiency, and developed tongue cancer, which was treated successfully, but it took 2 years to treat it. I have several other people whose only symptoms were frequent colds, sore throats, etc., and they have to receive gamma globulin infusions, as I do, to treat their immune deficiency. So I test for immunoglobulins at the first visit. We also look at total globulin. I could save the patient some money if I only looked for total globulin, which is part of a routine chemistry test. And if the total globulin is under 2.3, I get a breakdown of more detail on the immunoglobulins. Those are the oddball tests that I do. We'll do a standard blood count. We'll do called the CBC. We'll do routine chemistry, which also shows up some kidney tests. I'll do a 24-hour urine, which will measure for creatinine clearance and total protein, and also albumin and microalbumin, searching for early kidney disease. It's interesting that a number of years ago, I had a friend wanted me to treat his wife, who had just lost a toe. It was amputated. And she had been seeing the president of the American Diabetes Association. Well, one of the first things I do on everybody is get a 24-hour urine. And I discovered that she had almost no kidney function left. She had to right away go on dialysis. And here she had been seeing the president of the American Diabetes Association, and he never got a 24-hour urine. He never knew that she had end-stage kidney disease.
What would you say the value of a standard cholesterol panel is?
Pretty worthless. You may have heard the term cholesterol myth. For many years, dietary fat was blamed for high cholesterol, and high cholesterol was blamed for heart attacks and strokes. And it turned out that none of that was true. Mm-hmm. That researchers were being paid to change the conclusions of their research. And this was well documented in a famous article by Gary Taubes that got first published in the journal Science, and then in the magazine section of the New York Times. And he even wrote a book about it called The Big Fat Lie,
right,
where fat rather than carbohydrate and high blood sugars was blamed for all kinds of diseases, heart disease, cerebrovascular disease, dementia, etc. And it turned out not to be the case. So I will look at certain risk factors for heart disease that we know about, such as C-reactive. It's actually inflammatory markers. Uh, there's a lot of evidence that heart disease uh, is precipitated by inflammation. And high blood sugars lead to inflammation, and we could measure certain inflammatory markers like C-reactive protein. There's another marker called lipoprotein small a, which is probably the most single potent predictor of heart attacks that I've seen in my practice, because I've had several patients who have had a heart attack at a young age before they visit me. And each of these patients has had a high lipoprotein small a, LP little a. By the way, in women, you could lower LP little a if it's caused by lack of estrogen. People who have had total hysterectomies at a young age without estrogen replacement frequently have high LP little a and get early heart attacks. So I look at LP little a, I look at there is some possibility that apoprotein B is a predictor. High triglyceride, which is very much related to blood sugar, is a predictor. And low HDL, which helps prevent heart attacks, a low HDL is a predictor. So I check HDL, I check ApoB, I certainly check triglyceride, etc. Trying to think what else. We end up with a pretty expensive panel on a new patient. Mm-hmm. And as I said before, the 24-hour urine is extremely important.
So we know from your book that you actually do give a physical exam as well for new patients, and it's very thorough and extremely detailed. Are there simple things that people can do at home that will be able to determine their diabetic health? Not obviously as thorough as you, but just some indicators.
Well, people are now able to measure their own blood sugars. And you want to do that long before you get the long-term complications of diabetes. And my book tells you how to utilize your blood sugars, your blood sugar information, to keep them normal. By the way, way back then, Kirka 1969, 1970, I worked out a totally new way of treating insulin-dependent diabetes. In those days, you were getting one shot a day and then had to eat all day long to cover the big dose of insulin that you got from that one shot. And I thought, well, what if you had rapid-acting insulin before each meal and had a smaller shot of long-acting insulin, say twice a day, because if you had a smaller dose of insulin, it didn't last as long. So we would take a smaller amount of long-acting insulin, maybe a quarter or a fifth of what we were getting before, and divide it into two parts. One you'd get in the morning, another you'd get it at bedtime, and you'd take rapid-acting insulin before each meal. And the timing before the meal was determined by trial and error. And that finally has come to pass, as had blood sugar self-monitoring. Both of those were fought by the ADA for at least 10 years, and it's the reason I went to medical school, because I couldn't get published. And if the doctors at the ADA had taken my advice, I wouldn't have to get published. And I wouldn't have had to go to medical school. And I was really interested in physics. I would rather have been a physicist than a physician.
So one problem that we see in modern society especially is chronic overeating. So how would you plan to address that in patients?
Well, there are several approaches. One approach is that for many people, first of all, it's not just overeating. Many people have carbohydrate craving. They're addicted to carbohydrate. And we know the biochemistry behind that addiction. It has to do with competition for a transporter that transports a particular amino acid into the brain, tryptophan, which is the precursor of serotonin. Prozac and a number of the psychiatric medications that are used to treat depression are serotonin agonists. So carbohydrate helps raise the level of serotonin in the brain, and you can, because it makes you feel better, you could become addicted to it. So one problem is treating carbohydrate addiction. And as with other addictions, if you can stay off the carbohydrate for a few weeks or months, the addiction goes away. So most of the people who read my book and who try to stay off for a few weeks find that it gets easier and easier to stay off once you started it. So that's one approach, recognizing that the overeating is mostly carbohydrate. I have one patient who does not overeat carbohydrate. He's a lawyer, and they used to have meetings in his office, all the lawyers, and they'd serve cake and cookies and whatnot. And at those meetings, he'd succumb. But otherwise, he was not eating carbohydrate. He would just sit down, let's say for dinner, and if his wife made more than he was on his meal plan, he'd eat everything that was there. And we've used a number of medications to try to circumvent that. One set of medications called GLP-1 agonists were working, but he developed pancreatitis when he takes them. So, and recently the ADA, which had been warning that these medications can cause pancreatitis, took away the warning. And I've seen 3 or 4 patients get pancreatitis amongst the few that I've been treating with this drug. So it's a mistake to deny that they cause pancreatitis. In any event, we're now treating him with a new product called Quizmia. It's not that new, it's been around a while. It's a mixture of a stimulant plus an anti-epileptic drug called topiramate. Um, and it seems to be working for this guy. So I hope that he does not become tolerant to it and find that he needs higher and higher doses and uh, eventually becomes ineffective. But right now it's working. So we try, there are lots of uh, medications that we could try to treat the overeating, and there are different kinds of overeating. There's the carbohydrate craving, and there's just plain overeating.
Hmm. So to end off, what words of encouragement, what words of encouragement would you give to diabetics that are looking to regain their health and even thrive?
Well, read my book and do what it says. That's what I did, and that's what you did.
Yeah.